Dr. Balaga here. I have another terrific God Knowledge Doc podcast for physicians and advanced practice providers, including physician assistants and nurse practitioners. You should find this podcast very useful in your practice. This is a montage of the cover of many of the books I've either authored or edited, and many of the slides and figures are from these books. What is desirable cholesterol? The cholesterol levels are different among different human populations. In the hunter-gatherer humans, the total cholesterol is less than 130 milligrams per deciliters. And in the pygmies, it's even as low as 110 milligrams per deciliter. Whereas in the adult American male, the mean total cholesterol is around 210 milligrams per deciliter. And we know from the statin data that lower LDL cholesterol is better. LDL levels increase with age. After the age of 1 year, LDL steadily increase. There's a sharp rise from the neonate to the age of 1 year, up to 60 milligrams per deciliter. And after that, it continues to increase over the years. It's like my gray hair. With aging, the LDL levels of the bad cholesterol continues to elevate. And this left panel graph is from the European Heart Journal, reported recently in 2021. And on the right side is a table from JAMA, or a segment of a table which shows that LDL cholesterol increases with age. Between 20 and 29 years of age, it's about 121 milligrams per deciliter. And between 60 and 74 years, in men, it's about 148 milligrams per deciliter. In women, between 20 and 29, it's 113 milligrams per deciliter. And between 50 and 59, it's about 157 milligrams per deciliter. 60 to 74, it's 161 milligrams per deciliter. And this probably explains the high incidence of coronary artery disease 5 years after menopause in women. This figure is from a dyslipidemia handbook published by Oxford University Press, edited by myself and Dr. Chris Cannon from Harvard University and the Brigham and Women's Hospital. This figure, originally from the JACC Journal of 2004, shows a log linear relationship between LDL cholesterol and relative risk for coronary artery disease. This relationship is consistent with a large body of epidemiological data available from clinical trials of LDL lowering therapy. These data suggest that for every 30 milligram deciliter change in LDL cholesterol, the relative risk of coronary artery disease is changed in proportion by about 30%. The relative risk is set at 1.0 for LDL cholesterol equivalent to 40 milligrams per deciliter. Multiple clinical trials and meta-analysis have shown that the primary determinant in reducing atherosclerotic coronary vascular disease risk reduction is the absolute reduction in LDL cholesterol. Every 1 millimeter per liter, that is about 38.7 milligrams per deciliter, the reduction in LDL cholesterol is associated with a 23% relative risk reduction in major atherosclerotic cardiovascular disease events. A cholesterol treatment trialist meta-analysis showed that reducing LDL cholesterol by 1 millimole per liter results in a 10% relative risk reduction in all-cause mortality. Hot off the press is the Bempedoic acid clinical trial, the CLEAR trial, showing its efficacy. I would like to provoke thought in clinicians and scientists interested in dyslipidemia. Given the previous slides I discussed, the triple therapy with SEBA or the SEBA protocol, which includes statin, ezetimibe, bempedoic acid in many patients with elevated LDL, may be beneficial and maybe even preferential to injectable alternatives like PCSK9 inhibitors. The National Lipid Association, in their publication, suggested that in South Asians, that is from the Indian subcontinent, a target LDL of less than 70 is preferable for high-risk individuals, less than 50 for very high-risk individuals, and less than 30 for extreme risk individuals. And this is similar to infants and neonates in the graph I showed you earlier in this podcast. Now coming to hot off the press data with bempedoic acid, it's an ATP citrate lyase inhibitor. ATP citrate lyase lies upstream of 3-hydroxyl-3-methylglutaryl coenzyme A, that is HMG-CoA, the enzyme targeted by statins. Because of the very long chain acyl-CoA synthetase 1, ASCVL1 is required to activate bempedoic acid, and that ASCVL1 is not expressed in skeletal muscle. Bempedoic acid is probably inactive in skeletal muscle, and which could therefore reduce the risk of myopathy. So this cartoon here shows that bempedoic acid is inactive. Only after it enters the liver cell, it's activated, and it inhibits ATP citrate lyase, which is upstream in the cholesterol synthesis pathway, whereas ACSVL1 is not present in skeletal muscle, and therefore bempedoic acid is less likely to cause myopathy. Hot off the press is a New England Journal of Medicine article by the CLEAR trial outcomes investigators led by Steve Nissen. The title of the article was Bempedoic Acid and Cardiovascular Outcomes in Statin Intolerant Patients. Bempedoic acid, an ATP citrate lyase inhibitor, reduces LDL cholesterol and has been described to have less muscle-related adverse events. However, its effects on cardiovascular outcomes were uncertain. Therefore, these investigators conducted a double-blind randomized placebo-controlled trial involving patients who were unable or unwilling to take statins owing to an unacceptable adverse effects, or the so-called statin intolerant patients, and had or were at high risk for cardiovascular disease. The patients were assigned to receive oral bempedoic acid 180 mg daily or placebo. The primary endpoint was a 4-component composite of major cardiovascular events defined as death from cardiovascular causes, non-fatal MI, non-fatal stroke, or coronary revascularization. The study cohort comprised of nearly 14,000 patients who underwent randomization. Approximately 7,000 were assigned to bempedoic acid and around 7,000 to the placebo group. The median duration of follow-up was 40.6 months, that is a little over 3 years. The mean LDL cholesterol level at baseline was 139 milligrams per deciliter in both groups. And after 6 months, the reduction in level was greater with bempedoic acid than with placebo by 29.2 milligrams per deciliter. The observed difference in percentage reductions was around 21 percentage points in favor of bempedoic acid. So by reducing the LDL, by these percentage points, what these investigators found was that the incidence of the primary endpoint was significantly lower with the bempedoic acid than with placebo, 11.7% or 819 patients, whereas in the placebo group it was around 13.3% or 927 patients. The hazard ratio is 0.87 and a 95% confidence interval was between 0.79 to 0.96, and the p-value equaled 0.004, as were the incidences of the composite of death from cardiovascular causes, non-fatal stroke or non-fatal myocardial infarction. And for this, the hazard ratio was 0.85 and the p-value was equivalent to 0.006. Fatal or non-fatal myocardial infarction was also reduced, and the hazard ratio was 0.77 with the p-value of 0.002. And for coronary revascularization, there was also a reduction with a hazard ratio of 0.81 with a p-value of 0.001. However, bempedoic acid had no significant effects on fatal or non-fatal stroke, death from cardiovascular causes, or death from any cause. The incidences of gout and cholelithiasis were higher with bempedoic acid than with placebo, as were the incidences of small increases in serum creatinine, uric acid, and hepatic enzyme levels. The authors of the study concluded that among statin-intolerant patients, treatment with bempedoic acid was associated with a lower risk of major adverse cardiovascular events, including death from cardiovascular causes, non-fatal myocardial infarction, non-fatal stroke, or coronary revascularization. This trial was funded by Esperion Therapeutics. The actual prevalence of statin intolerance is a topic of dispute or debate, and a recent meta-analysis places the overall rate of approximately 9%. Conditions such as diabetes, obesity, older age, chronic liver disease, and chronic kidney disease appear to increase the risk of statin intolerance. High-intensity statin therapy has been advocated for all patients with established atherosclerotic vascular disease, as well as those at high risk for atherosclerotic vascular disease. However, a sizable portion of this population, approximately 10% of those who would benefit from statins, are unwilling or unable to take them, primarily owing to muscle-related symptoms. This trial has shown that bempedoic acid is beneficial in these patients. Once again, the percentage of patients with muscle aches and myalgias was similar in the bempedoic acid group and the placebo group, but the incidences of gout, cholelithiasis, gallstones, and laboratory elevations in creatinine, uric acid, and liver enzymes were higher with bempedoic acid than with placebo. There is no question that these compelling results of this clear outcomes trial will increase the utilization of bempedoic acid in patients with established atherosclerotic vascular disease and in those for high risk for vascular disease who are unable or unwilling to take statins. In an accompanying editorial, John Alexander, MD, in an editorial titled "Benefits of Bempedoic Acid Clearer Now." This editorial is in NEJM, and Dr. Alexander is at Duke Health. He says it's premature, however, to consider bempedoic acid as an alternative to statins, given the overwhelming vascular benefits of statin, he advocates that clinicians should continue their efforts to prescribe them at max tolerated doses for appropriate patients, including those who may have discontinued statins because of presumed side effects. Although bempedoic acid also reduces LDL cholesterol levels in patients taking statins, the clinical benefits of bempedoic acid added to statin therapy, he says, are unknown. He says 2 observations from clear outcomes trial warrant further exploration. First, given the pathobiology of atherosclerosis, the suggestion of a greater effect of bempedoic acid in the primary prevention cohort than in the secondary prevention cohort is probably due to chance. He says it's possible, however, that in patients may benefit more from bempedoic acid when administered early in the course of atherosclerotic disease, or that concomitant therapies diminish the benefits of bempedoic acid in secondary prevention cohort. The second observation, he says, which warrants observation, is the fact that bempedoic acid had no observed effect on mortality. Again, this could be due to effective concomitant therapy treatment, and that the observation periods were too short, or the actual absence of an effect of bempedoic acid on mortality. He goes on to say many individual trials of statins have not shown an effect of the agent in mortality. It's only through the meta-analysis of multiple clinical trials the effects of statins on mortality became clear. In another editorial regarding the science behind the study, titled Bempedoic Acid and the Prevention of Cardiovascular Disease, Dr. John Keeney, Jr., MD, says that it's generally accepted that the contemporary statins produce a 22% reduction in the risk of vascular events for each reduction in LDL cholesterol level of 39 milligrams per deciliter or 1 millimole per liter. And this response is roughly linear. He says it's also accepted that high intensity statin, that is greater than 20 milligrams of rosuvastatin or 40 milligrams of atorvastatin, should yield a reduction in LDL cholesterol levels of approximately 50%. Therefore, it is clear that considerable risk reduction of cardiovascular events can be achieved with statin monotherapy. Bempedoic acid monotherapy lowers LDL cholesterol levels by 28%, and this effect is attributed to approximately 16% in patients receiving maximum tolerated dose of statins. The clear outcomes trial, he says, also showed that bempedoic acid, when used in addition to modest cholesterol lowering therapy, led to a reduction in LDL cholesterol level that exceeded that of placebo by 29 milligrams per deciliter or 0.75 millimoles per liter, a finding that corresponded to 13% lower risk of cardiovascular disease. This corresponds between a reduction in the LDL cholesterol level and a reduction in the risk of cardiovascular events is on par that observed with statins. However, determining whether bempedoic acid is preferable to statins, Dr. Keeney says, would require a direct comparison trial, which is unlikely to be realized with patients who are able to receive statins, given that it would be unethical to do so, unethical to withhold statin treatment from them. Rather, he says, the most likely scenario in which a choice would need to be made between bempedoic acid and statin would be for those patients with statin-associated adverse events, such as myopathy or diabetes, which could in theory be avoided with bempedoic acid. Another point he makes about side effects from the clear outcomes trial is that it did not show a clear association between bempedoic acid and muscle disorders, new onset diabetes, or worsening hyperglycemia, which is, he says, welcome news for statin intolerant patients. However, these data must be interpreted cautiously, he cautions, because bempedoic acid, when combined with a statin, appears to enhance the occurrence of muscle symptoms. In addition, bempedoic acid has its own side effects, including tendon rupture, increased uric acid levels and gout, reduced GFR, which are not seen with statin use. Another important side effect is a drug interaction. Bempedoic acid can increase circulating levels of simvastatin and pravastatin, so it should not be used in patients who are receiving these agents at doses above 20 milligrams for simvastatin and 40 milligrams for pravastatin respectively. Similarly, bempedoic acid should not be used with fibrates other than fenofibrate because of concerns regarding gallstones or cholelithiasis. Finally, Dr. John Keeney asks the question, where does bempedoic acid fit in with other cholesterol lowering therapies? This study clearly shows that bempedoic acid can be used as an adjunct to statin and non-statin therapy, except as discussed before, to produce an additional 16 to 26% reduction in LDL cholesterol level. However, he says it's not yet clear to what extent adjunctive bempedoic acid will further reduce the risk of cardiovascular events. He says this issue can be addressed with specific trials powered to detect the effects of bempedoic acid on clinical events. However, at least in statin intolerant patients, he goes on to say that the data from the clear outcomes trial indicate that bempedoic acid may reduce both LDL cholesterol level and the risk of cardiovascular events. Now I'd like to bring your attention to the small study which used a combination of atorvastatin, ezetimibe, and bempedoic acid. The mean age of the cohort was 60. For the 63 randomized patients was around 61 years. And when they used the triple therapy, or the SEBA protocol, as I say, it significantly lowered LDL cholesterol, allowing more than 90% of the patients in the study to reach guideline recommended LDL cholesterol levels. This could be an option to people who don't want to take subcutaneous PCSK9 medications. We need more data on tolerability, efficacy, and cost for this approach. Lastly, I'd like to discuss the Fourier-OL trial, that is the Fourier open label extension studies, the US and Europe. The primary analysis was pooled across studies. The primary endpoint was the incidence of adverse events. Lipid values and major adverse cardiovascular events were prospectively collected. 6,635 patients were enrolled in this open extension study. Around 3,355 were randomized to evolocumab and the remaining to placebo. The median follow-up in this extension study is 5 years. Maximum exposure to evolocumab in the parent plus Fourier open extension study was 8.4 years. At 12 weeks, in Fourier-OL, the mean LDL cholesterol was 30 milligrams per deciliter, and 63.2% achieved LDL cholesterol less than 40 milligrams per deciliter on evolocumab. Incidences of serious adverse events, muscle-related events, new onset diabetes, hemorrhagic stroke, and neurocognitive events with evolocumab long-term did not exceed those for placebo-treated patients during parent study, and did not increase over time. During the 4-year open-label extension follow-up period, patients originally randomized in the parent trial to evolocumab versus placebo had a 15% lower risk of cardiovascular death, MI, stroke, hospitalization for unstable angina or coronary revascularization, a 20% lower risk of cardiovascular death, MI, or stroke, and a 23% lower risk of cardiovascular death. This is hypothesis generating, and we need more studies to have a better understanding on the effect of evolocumab on mortality. Finally, the CLEAR trial has shown us that bempedoic acid is an important medication, particularly in patients who are intolerant to statins due to muscle aches and other related issues. It is efficacious, and more importantly, this may be the foundation for triple therapy with the SEBA protocol, that is statin, ezetimibe, and bempedoic acid, particularly in patients who do not want to take subcutaneous injection with PCSK9. More data is needed to determine the efficacy and safety of triple therapy for lipid lowering.